It will be presented by Dr. Cook Bakari Zimwe. Dr. Zimwe is an hemato-onco clinical pharmacist. He's a BMT clinical pharmacist, an infectious disease clinical pharmacist with leadership roles in antimicrobial stewardship, sickle cell disease, and pharmacy mentorship across Africa. He's from the Republic of Tanzania. So Dr. Zimwe, if you're ready, you may proceed.
Yes, I'm ready. Yes. Good evening, everyone, and I'm okay. I'm very sorry for late connecting because of the network problems. So I'd like to welcome you in this session. And there are a lot of clinical pharmacists in a different pediatric oncology discipline. As I've been introduced, my name is Kauke Zimboy. So this is supported by South Africa. I have no webinar audience. This is my personal statement. So I have no relevant financial relationship to disclose as related to the content of this presentation. So the learning objective of these presentations, to the end of the presentations in these sessions, we are expecting to have them to describe the role of clinical pharmacists in different pediatric oncology discipline. And the learning objective, specifically, we'll see to outline on medications, management, dosing, and interactions, to describe patient safety, monitoring for adverse effects, to outline guidance through therapeutics recommendations on optimization of treatment, to outline patient and the family educational program for pediatric cancer patients, and also to identify roles in managing medications for different pediatric subpopulations. And then lastly, we're going to see to outline the supportive care management for pediatric cancer patients. So, you know that the clinical pharmacist is offered by pharmacists services when deciding and monitoring the patient pharmacotherapeutics. So this is a big role in the big interventions in the clinical aspect, especially when we emphasize from the bench to the bedside. So the global clinical pharmacists started after a surge of increase in the burden of the drug-related morbidity and mortality. This is from the research which have been done in northern Brazil. So this is one of the things which was being observed, that the increase of the number of the cases of drug-related morbidity and mortality are one of the triggers that requires pharmacy to be aside the doctors, aside the prescribers, nurses, and the patients, so that to make the reconciliation very easy, especially for drug-drug interaction and the adverse drug reactions. Clinical pharma services requires pharmacists to optimize the patient medication therapy and they promote healthy wellness and disease prevention. And the major areas where CPS is well established globally are in hospital setting, especially in healthcare facilities, ambulatory care facilities. Community pharmacies is common in Africa. Most of the pharmacies there provide some educational prescribing for the counter medications, dispensing of medications, provide education to the community. And in some part, especially drug regulatory authorities nowadays, because most of the drug regulatory authority in Africa, they conducting the clinical trial, pharmacovigilance and the vigilance, drug registration, where you can find clinical pharmacists and their contribution. In academia, also clinical pharmacists provide a big role, especially for training, ward round. We call them the junior and the senior clerkship for pharmacy residents. Drug research and the development firms, this is one of the critical areas where it is emerging right now. Most of pharmacists are being engaged in the drug research. Health policies and the regulations is one of the key important areas whereby the pharmacists can have a good contribution, especially to ensure there is involvement of pharmacists in development of health policies. This including the treatment guidelines, SOPs, policies, policy brief, and then for the world of antimicrobial stewardship, where the clinical pharmacists play a great role, especially in development of national action plans for antimicrobial resistance. At a global overview of clinical pharmacy services, among the countries that accepted and integrated the services within their health system, and this is most of them the Western countries, United States of America, Canada, Spain, and Brazil. And then later come after that one, Europe, some country in Europe, also Asia, Africa countries like South Africa, Egypt, are the early 19th countries where they have been introducing clinical pharmacies in their, is it being integrated in the health system? So this is what we can see. So in the developed countries where the clinical pharmacy services is well established, reduction of adverse drug reaction was observed. So that's an advantage of integrating healthy in our health system, the clinical pharmacy services. Medication errors, including dosing errors and the misinterpretations, also declined. Hospital stay, especially for maybe the secondary infections, hospital-acquired infections, inadequately medical reconciliations, ensures there is a reduction of the hospital stays, because it's when the pharmacist can play a great role on the selection of medications, review of history, review of medications, review of laboratory investigations to share together with lab scientists, doctors, etc., to ensure there is the better selections of medications, also to avoid overstays of the client. Hospital readmissions, and especially for infections and the treatment failures, was also assured with the presence of the pharmacist, clinical pharmacist in his capacity, especially in hospital. Drug-drug interactions, which normally is more prominent for comorbid diseases, like someone have a chronic disease, even for pediatric cases. The kid can have cancer, but also infections and others related diseases. For more diseases, I'm sure a lot of medication will be prescribed. Those can trigger the drug-drug interactions and so forth. And also we have the drug-food interactions, and the pharmacists who have the knowledge of medicines and the custodian of the drugs provide a key role in integrations of patient behaviors, the social integrations when the medication is being prescribed, especially for oral anti-cancer drugs. Even for intravenous chemotherapy, is where the pharmacist can provide a better advice on how the interaction can be happens and how to reduce them, looking at the time for administrations for our clients. So we have the drivers, we have seen the diverse scope of the clinical pharma services in high-income countries and the low-income countries. So the full clinical pharmacist interventions, this is to have the bench-to-bedside practice. And this we have seen a reduction of adverse drug reaction. We have seen this one. Medication errors, hospital stays, especially for high-income countries, there is a decline of all of this one. Drug-drug interactions, drug-food interaction have been evidently reduced. And they promote medication adherence, lower treatment costs. This is all aspect because the clinical pharmacists also have a big impact on the pharmacoeconomics perspective, pharmacoeconomics consideration, which medication will be used, maybe a first line, second line, and third line medication. The choice, the cascade of choice, considering the ladder of choices, especially fighting emerging antibiotic resistance, building the reputations of facilities, raising public confidence in the healthcare system. In low middle income countries, whereby most of us, we are working on the bench works, dispensing, compounding, procurement of medicines. So we are local medicines manufacturing, the supply chains and the inventory management, compounding, and the medicine dispensing. These are the key role which we play, and thus lead to the less practice of CPS in our country, especially in MSc. So training and the qualifications. If you look at diversity in Africa, we're looking on the West in Northern Africa countries. Most of the countries there, they have already integrated the clinical pharmacy services, even the scheme of service itself. So from the country level, they have been able to identify, to recognize the professional. So when you look to in Egypt, so you can see the Bachelor of Pharmacy. There's someone who have the Bachelor of Pharmacy have to go for PharmD or clinical pharmacy, and they can do MSc for subspecialties, like cardiovascular, oncology, etc. So when you look for the West African countries, by doing the clinical pharmacy specialties, fellows and the clinical fellowship and the clinical pharmacy in oncology, these are the subspecialties which someone can specialized from the clinical pharmacy and they can be recognized. But in South Africa, it's only South Africa, I think, which have much evidence, whereby someone who to have the clinical pharmacy, have the master of the pharmacy in hospital, clinical pharmacy, or equivalent combination of educational training and experience in MSc for subspecialties and having the bachelor of degree of pharmacy, etc. These are the things which is someone to be a clinical pharmacist, they have to get through these procedures and the steps by steps in order for him or her to become specialized clinical pharmacist. So looking on the west from the East Africa, so they are still there, especially from my country, Tanzania. It is not yet recognized within the scheme of service, but the courses is being available in a single university, Muhimbili University, but it's not yet in the scheme of service in being recognized by the government of Tanzania. So the scope of a clinical pharmacist. So we have a lot to do. If you see in pediatric oncology, in oncology itself, in other aspects of the clinical services, the clinical pharmacists have a lot of the responsibility and the scope to practice. So, and the medications management and the dosings and interactions, these are the key aspects of doing the clinical pharmacist, the roles, medication therapy reviews, doing the pharmacotherapeutics consultations, disease management, like coach and the support, pharmacogenomics and the biomarker applications on the treatment individualizations. This is one of the emerging science. And we expect the clinical pharmacist can play a great role on the integrations of the biomarkers, integrations of pharmacogenomics, especially in the treatment, in cancer drugs selection, especially for precision medicines, for biosimilars or biologics drugs. This is where we have to integrate all issues regarding the pharmacogenomics. So we expect the clinical pharmacist to be able for him or her to be in a good way to advise, especially pharmacogenomics considerations or pharmacogenomics counseling to maybe to prescribers or to client for the families, integration of precision medicines like small substances or checkpoint inhibitors, etc. You need to be good on the pharmacogenomics or biomarker applications in treatment individualizations. We have the anticoagulant. This is the integrations of difference of the coagulation factors like international normalization ratios, prothrombin times. These are things which can guide and you can provide the substantial work during the word round or during clinical meeting with the prescribers. The clinical pharmacists also have being able to also to do like a patient clinical review, looking on the history of present illness, post-medication history, etc. This can allow and make the functions and activities easy in ward round or in the clinical meetings. Medication safety surveillance review, health wellness, public health advocacy, immunization programs, and adverse drug events assessment. On the patient safety monitoring for adverse events, the clinical pharmacist is do the monitoring of patients who are great risky, especially for pediatric monitoring, also patient prescription on the drugs more likely to cause adverse drug reactions, assessment of the patient history of allergic reactions, and for children is very important, and for pediatric oncology is very important task for we to consider and sometimes to advise families and the prescriber. And it is very important, especially for naive patients, the new patient who come for initiating the chemotherapy. It's better. This is a time to get the clinical pharmacist only clinics to provide advice or to know if the patient or if the kid have any allergic reactions or history of allergy. So in healthcare professionals, detections and assessment of ADRs in OT and the clinics, prompt documentation and reporting. This is very important. This is very important. Most of us, we are doing a great work, a great job, but we are not documenting our work or sometimes reporting to show what we provide, to show our capacities. Follow-up to assess the outcomes of ADRs and the possible management, and the education of healthcare patients and the families on the reporting of ADRs and unusual things that are apart from the anticipated or severe side effects. So the guidance through the therapeutics reconciliations on the optimization of the treatment. So we have the three part, which is very important for clinical pharmacy aspect in pediatric oncology. The first one is intervention in optimizing prescriptions, pharmacotherapeutics, patient follow-ups, and interventions. Clinical pharmacy in interplay in technical counseling. And for the first one, when we wanted to optimize the therapeutic treatment in the ward, in clinic, in the clinical meeting, etc., even in consultations. So when you are doing interventions in optimizing prescriptions, so first thing is you validating the prescription for optimal regimens, dosings. Like, for example, for looking for antimicrobial stewardship, we have the OPAT system. OPAT system is oral to parenteral therapy. So this is the system whereby you are looking on how to convert on patient therapy on how to use antimicrobial to optimize antimicrobial use for a client, and also dosing in for cancer treatment. Dosing in cancer treatment is sometimes very challenging. It's very challenging. If you can go down, you can see the same dosing will be initiated from the naive patient, but in subsequent cycle, still the kid was on the same dosing. So this is a place where the clinical pharmacist can make some interventions, looking if there is a need for recalculations of dose, recalculation of the body surface area to volume ratio, so that to see if there is a need of it to escalate, to reduce the dose or to increase the dose. So they're proposing the potential treatment or alternative regimens, especially for antimicrobial resistance in case of febrile neutropenia, drug interactions, renal failures, and renal failures and the liver failures. So those adjustments is very important also by considering the end organs failures, like drug interactions also. If the drug interactions which can reduce the dose or can increase the dose, can reduce the metabolism or increase the metabolism of certain drugs. Renal failure also, this can lead to the accumulation of some drugs, especially for renal dependent drug to be excreted. And the liver failure also for those which need merely liver for metabolisms, and the biomarker titers is very important also for this could be done also for infectious diseases, etc. Also, the intervention of optimizing the prescriptions, optimizing the pharmacodynamics, pharmacokinetics parameters in a pediatric cancer patient. This is very important, especially you know that after a long time, the patient can suffer from the different complications like lower GI and the upper GI complications. And especially for upper GI complications, the patient can have nausea and vomiting. Sometimes you need to change some route of administration so that the patient can take the same dose which has been required because of the severe nausea and the vomitings. And oversee intravenous drugs administrations and the IV oral shift. This is very important. If you find some situation whereby, especially in our country in Africa, someone is being discharged to go home with intravenous medications, especially maybe intravenous antibiotics, but you are not sure that where he or she go, there is maybe there is health centers or health professionals who will be able to administer that medications. So this is very important practice in pediatric unity, in pediatric oncology unity, to have the IV oral shift integration system, so that to know better conversion of certain IV to oral, so that the patient can get the same dose or the equivalent dose which is expected, but also in the case of antimicrobial, the same medications will be able to treat the certain type of pathogens. Pharmacotherapeutics patient follow-ups and interventions. So medication reconciliations and the treatment plan review, this is very important. Identify patient potential anticipated medications allergies, especially we know that R-CHOP is most commonly prescribing regimens in pediatric oncology, could be used especially for CD20 positive. Rituximab is being prescribed, and you know that for a naive patient who not yet use rituximab, there are some reactions can happen. So it's better to know that you should have the supportive medications like paracetamol for fever and the other antihistamine for allergic reactions if it will happen. Therapeutics drug monitoring and the use of point of care investigations. like immunosuppressant, anticoagulant, C-reactive protein, galactomannan for fungal infections. This is a very important aspect, especially for post-bone marrow transplant patients who are under immunosuppressant. So your normal emphasis for pharmacists to have the good interventions, the good knowledge, the good aspect on how to advise, on how to make interventions, sometimes to request some lab results or investigation, so that to have the good way to advise for hematologist or pediatrician or pediatric oncologist. Clinicians and clinical reviews and advice on medication treatment plan, monitoring and managing adverse drug reactions. In clinical pharmacy interplay in technical counseling, this is another role whereby clinical pharmacy services play in the pediatric oncology, proposing the setup of pharmacy and the dispensing workflow. This is our role, and we have to know that this is our, especially if you have the reconstitution room, chemotherapy room, whereby you're reconstituting your medications for sterile preparations and mixtures, it's better to know the workflow. It's better to know the documentations which are required before reconstitutions on the delivery of medications ward. Assessing and determining capabilities of solvent and the devices for administration, analyzing and provide guidance on final concentration, on infusion after dilutions or reconstitutions, oversee administration protocol and the use of pump for certain medications like anti-cancer antibiotics, and even for anti-pain like narcotics drugs. We know that we have those controlled administration of morphine and other narcotics medications. So this is very important because in case like your patients on certain medications which need to be regulated in intravenous infusions. So it's better also to ensure the hospital have the infusion pump, the hospital have the injection pump, the hospital will be able to control the administration of the drugs slowly to prevent other complications which would associate by the bolus administration or quick administration. Ensure adequate and sterile compounding, reconstitution, dilution, storage, and maintaining the quality of the drug. The patient and the family educational program for pediatric cancer patients, this we have spoken about this one. We know that the clinical pharmacy services in pediatric oncology have the great role in patient counseling, healthy promotion, medicine management, community awareness and advocacy, the disposal of unfit to use medicines, and sometimes to provide education on how to keep medications, contraception, and demonstrating the procedures, techniques in the use of the equipment, medicines handlings and adverse drug reporting, screening services and immunization program, community pharmacy and the dispensing, palliative care, and the nutrition. Palliative care and nutrition are the key issues which most of pharmacists are too back. They are not show up in the palliative care to advise the palliative care team in selection of anti-pain, in selection of the treatment, and even for psychological treatment. And this is the place whereby a pharmacist will ensure that the clinical pharmacy services will assure the application of the WHO pain ladder, which will ensure the proper way of selecting the anti-pain treatment of pain for patients who in palliative care. So role in managing medications for different pediatric populations, this is one of the critical role we have to understand. But the challenge, because most of these roles are based on the subspecialties. So if a clinical pharmacist who can go further, maybe to do infectious diseases, a fellowship in infectious diseases, or a fellowship in bone marrow transplant, or any attachment, or any clinical attachment. First of all, the first is oncocritical care. We know that in critical care, we have a lot of polypharmacy and comorbidities. And some patients can acquire secondary infections, etc., because of maybe devices-related infections or other complications. So those calculations and reconciliation of choices of route and dosage form is paramount. Pediatric oncology and the renal failure and the liver failure, this is one of the key important aspects in some populations. Pharmacokinetics considerations, the trough and the crest plasma concentration for aminoglycoside is very significant to be considered, and other drugs like antidepressant and other medications for seizure, etc. Enzymatic inducers and inhibitors, managing toxicities and the dose adjustment is a key aspect of this in this area. Palliative care also have spoken about pain and anxiety management, the use of medication, the choice to ensure available medication are there, to treat disabilities, bed sores, and management. Pediatric cancer patients with resistant infectious diseases, especially for hospital-acquired infections, pneumonia, opportunistic infection, including TB, you find that your child, because she or he already have cancer, so he's totally immunocompromised. Or she's post bone marrow transplant, it also is immunocompromised. So the patient can be in the very danger to acquire some opportunistic infections. And so that you have to ensure the available medications, but you are a pharmacist have the ability to make any interventions in case of opportunistic infections being available, but also to ensure there is available prophylactic medications like ganciclovir, valganciclovir, ceftriaxone, which is cotramoxazole, etc. Device-related blood infections, preventions, and management. Pediatric oncology and immunization is very important, especially to update vaccine influenza and the screening like HBV, preventions of viral infections using the ganciclovir and the valganciclovir commons. This is one of the part of the opportunistic infection, especially for immunocompromised patients like post-bone marrow transplant and for pediatric oncology patients. Pediatric oncology and the nutrition, and this is one of the key aspects, especially for clinical pharmacy services, to ensure availability of TP and total parenteral nutrition and other formulations to be prepared in-house, or sometimes you can buy it from the suppliers. And the hematopoietic stem cell transplant, this is another aspect. It's a huge aspect, and emerging science is emerging clinical services in Africa. And right now we have very few centers which provide bone marrow transplant, etc. So the conditioning regimen, complications, and immunosuppression. The conditioning regimen is all about chemotherapy. Most of them are chemotherapy and immunosuppressant, and most of them they are used with at a lethal dose. The lethal dose which need the close eye, the close presence of a pharmacist in calculation, in preparation of the dose, administration, etc. And after discharge, to see the patient is on immunosuppressant regularly, but also to see there is adherence of taking therapeutic drug monitoring, especially for cephalosporin, tacrolimus, etc. So supportive care management for cancer patient, this is one of the things which we have to provide, and we have to give them great role, especially in clinical pharmacy aspect in pediatric oncology. Development, use, implementation of clinical practice guidelines for pediatric oncology unity. So if you find a pharmacist who is not able to develop this one, the guidelines, it is better to get some training, maybe to adopt it from different centers, so that you can have the document as a check and balance, so that to see there is adherence. If there is no adherence, where to refer, how to interpret maybe some results, etc. Empowering patients and families, and giving children to understand their medication, having the pharmacist ward round, having the pharmacist clinic, a reconciliation with family, knowing how to take medications, knowing how the side effect will be reported, what happens, and to know with all aspects of his or her medications, and for the family it's better also. Addressing psychosocial factors, especially in case of the economics impact, the needs, medication of patient and the family, using patient-reported outcomes, routinely on pain management, nutrition, and psychosocial, recognizing benefit and actively incorporating early palliative care, and be part of the team. To initiate palliative care as early as possible, and the pharmacist should be part of the team. So that advice, as I said, in pain management, in some antidepressant medications choices, etc. Optimizing survivorship, reducing late effect, promoting survivorship research. And this they're very simple research doing, like these are the this we call them a service improvement research. These are we'll just use the maybe qualitative methodology can be used there. Looking for we initiated this program. So you want to check how far there is a success or there is a challenges, how the patient perceive your services, are they satisfied with your services, what area to be improved. This is a very important aspect in clinical pharmacy services in pediatric oncology. embedding the general pediatric and the environmental care into oncology care, leveraging the technology to study to improve supportive care. Alternative medicine also can be initiated, especially provisions of maybe like supplement, which is being available, but should be safe and not interfering in the pharmacological action of conventional medications, which are being provided, or anti-cancer, which was being provided for your patient. So the challenge facing the implementation of CPS, especially for middle-income countries, looking from the high-income countries. In developing countries, the challenge is just inadequate pharmacist training. Who training in CPS, but the system is there, and the system, the benchmark is there, and the scheme of service understand the role of clinical pharmacy services. Poor mentorship and the peer support, pharmacist personalities. Sometimes this is the challenges. Someone to show up in front of the among the prescribers, nurses, and clinicians, so that to provide his contributions. Lack of pharmacists defined roles. Sometimes this is a big challenge. You don't know the functions and the role responsibility for clinical pharmacy services or for clinical pharmacists to provide during the ward round or clinical services. Shortage of resources and the fund. Mistrust among the healthcare providers, especially when you wanted to advise maybe changing of regimen, changing of medication is a big challenge. It's a big challenge, especially in many parts of the world. But for myself, I've witnessed here in Tanzania is a big challenge. When you want to advise, maybe clinicians become very reluctant on how say I know about this and know about this. So this needs a lot of effort to make some emphasis, especially for PSYOP. This is a good area also to make some integrations because the PSYOP is a multidisciplinary society. So it is a great role also to ensure we have the common understanding, especially as far as the patient health is concerned. In LMIC, we have the challenges like a lack of guidance policies, like the understanding the role of clinical pharmacists. Universities use all the curricula to train clinical pharmacy. You don't see most of the clinical pharmacists that use a lot of time in wards. They are using a lot of time in classes. This is a big challenge. So even after graduating, the clinical pharmacists still have a huge effort to make so that to tackle some clinical conditions or clinical cases. Inadequate motivation in the scheme of services. So someone can go to study clinical pharmacy, is a master's of pharmacy, 2 to 3 years, but when he come back or she come back to work, so there's no any increment of salary or any incentives. So this makes some guys to be heartbroken, so they cannot are volunteering to go to study the clinical pharmacy. Inadequate motivations, lack of on-job training, and other barriers. This is generally inadequate clinical and communication skills, assertiveness, perceptions among pharmacists, and the historical dominance of the medical doctor in healthcare. This is what we found in our settings. We see in every system, especially in Africa, in every system we find the top, there is the medical doctor, so the others will become the maybe subordinate will become other healthcare professionals. But you can find the clinician will be given the first priority, even in employment. In conclusion, skills and abilities. So the clinical pharmacist in pediatric oncology unit needed to have first, broad knowledge on organizations, policies, procedures, and the standard of care, knowledge of evidence-based clinical pharmacy practice, knowledge of medications use evaluation, knowledge of research processing methodology, knowledge on drug distribution process in the hospital settings, to apply clinical pharmacy knowledge, make decisions within minimum supervisions, to establish and minimum to communicate effectively both verbally and in writing on all aspects of clinical pharmacy services. Establish and maintain effective working relationship with other health practitioners as well as patient, family member, and public. To organize and prioritize work, to operate related equipment, because we have different equipment, also pharmacists have equipment. Some pharmacists also have to know some medical devices because you are the one who can devise how to use certain type of syringes. You know, this is a lower lock syringe. This is just, this is one of the common syringes. This is an infusion pump, how to use it, how to calculate the doses. This is very important also. Ability to carry out duties of these positions as a clinical pharmacist. So thank you so much.
Thank you. Thank you, Dr. Zimwe, for this very informative lecture. It helped us really understand better the role of clinical pharmacists in different settings of pediatric oncology. So, dear attendees, if you have questions, you may raise your hand or you can write them in the chat box if you prefer. Any questions?
I see Johnny Isiko.
Okay, thank you very much for this very paramount presentation. Indeed, it is informative and it is very good as far as clinical pharmacy practice is concerned in oncology. So just asking about how the issue of training in oncology is concerned, especially in our continent of Africa, because you may find people may have interest in specializing in oncology pharmacy particularly, but the obstacle of accessing a specialized training becomes a challenge. So how best can we address this issue, given the fact that it is very expensive to acquire such training from abroad? Thank you.
Thank you so much. And I think this question, it will be better to be answered with the PSYOP Farmers Group. But I can try to, maybe others can add, especially from PSYOP. Right now, we are working, especially the PSYOP Pharmacy Group as one of the member. I'd like to say that we are working greatly on how to ensure we have particular a curriculum on the pharmacy, for the clinical pharmacy aspect in pediatric oncology. Because we have seen the demand, we have seen the need, the doctors, clinicians, pediatric oncologists that really require, they really need of pharmacists to be on their side to advise, to make some intervention, etc. And so I don't know in the other part of Africa, but what I know right now is just we have Nairobi University provide, and also Cairo Cancer Institute, I think that one, also provide some MSc in pediatric oncology, etc. But in Nairobi University, it's just MSc in general oncology, but it's not specifically in pediatric oncology. But so maybe you can keep in touch with the guys in the PSYOP group so that they can find you the way on how to connect you on the different institutions, especially for pediatric oncology or for oncology itself. But currently, we are really working hard as a PSYOP group, pharmacy group, PSYOP Pharmacy Group Afro, to ensure we have a book specifically for pediatric oncology. At the same time, we have the curricula for training for pharmacists to specialize in pediatric oncology. So, PSYOP Africa, do you have any addition?